Welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology. I would like to thank Dr. Amit Pandya, who will be leading our vitiligo panel. Dr. Pandya also needs no introduction. He's a world expert on vitiligo and all therapeutics, and we're lucky now to have him at the Palo Alto Medical Foundation. Our patients that we send to him usually don't even come back to us because they just say, no, I'm going to stay here. Now, he is so fantastic. So thank you so much for leading this session.
Thank you. Thank you, Farah. Well, it's really hard to follow that. Oh no, I'll pass on the shawl. Thank you. Yes, I'll need an orthopedic surgeon if I wore those shoes. That's for sure. Well, it's a pleasure for me to speak to you this morning on vitiligo. For those of you who don't know me, I had pretty much my whole career in Dallas, and that's where I thought it would be. But I met a lovely woman in 2017. In 2018, we moved here, and we've been here for almost 5 years, and we love it here. And I want to thank all of you, especially the private practicing community, but also the UCSF and Stanford for welcoming me and giving lectures, and also especially Erin Emerson and Kieran Leslie for welcoming me to San Francisco General Hospital, where I volunteered to see pigmentary patients. It's just been great to be part of the community here. And thank you for all your referrals at our clinic. I direct the Pigmentary Disorders Clinic at PAMF in Sunnyvale. And that's all I do exclusively. See patients with vitiligo, melasma, lichen planus pigmentosus, erythema dyschromicum perstans, et cetera, and then those in which the diagnosis might be difficult. These are my disclosures. Most of this has to do with JAK inhibitors and other products that are being developed for vitiligo. This is the most exciting time in my career for vitiligo because up until recently, we didn't have anything really to offer that was FDA approved. Now we do, and there are more that are coming up. All right, well, I'm going to give a brief talk about how to approach the patient with vitiligo, and then Dr. Hamzavi is going to talk about treatment, and then we're going to give you some cool cases so you can kind of decide how you would take care of them, and then we're going to kind of ask each other how we would handle them, and then you can learn from us. And then I want to remind you there is a what do you call those codes? Those stamp things that you have to take a photograph of if you with your camera. Thank you, QR code. Yes, I'm from the old school. I'm probably still using paper charts if I could. But you'll have to use that if you want to ask a question. All right, well, as you know, vitiligo is common. About 1% of Americans have it. That's 3 million people, 70 million people worldwide, and yet there are so few doctors who really focus on it and care for these folks, and they feel kind of abandoned, and there's not really people that can take care of them. All races are affected. I had a Swedish patient who had vitiligo. Nobody cared, nobody knew back in Sweden. She moved to Texas, and now everybody could see it because of her tan. It seems to be about the same percentage worldwide. Some have learned to embrace their vitiligo. It's amazing when you look at the African-American community, how that community comes together with someone with vitiligo. And yet there are other communities in which it's a stigma. It's a reflection of moral status. It's a reflection of bad karma from the sins you committed in your previous life. When you see these patients and the stress they have with vitiligo, you may not realize all the layers that come behind that stress with vitiligo. And yet there are some who have come to embrace it. So every patient needs to be approached in their own unique way. The disease course, unfortunately, is unpredictable. Doctor, I'm scared I'm going to wake up tomorrow with a new white spot on my face. That bothers people just as much as just the existing lesions. And we don't have any biomarkers, so I don't have a SED rate that I can follow and say, your lupus is going to be worse in 3 months. I don't have a SED rate. I don't have a biomarker for vitiligo, but we're working on that. The peak age of onset, unfortunately, are young people. This is where they're developing relationships. This is where they're going from being a child to an adult, and this is when vitiligo hits them, and it can be one of the most stressful things that a person can face from that. And there's an increased risk of autoimmune disease. The main one is thyroid disease. 15 to 20% of vitiligo patients develop autoimmune thyroid disease. So that's really all I check for, a TSH once a year in adults, and that's about it. If you're going to understand vitiligo, you have to understand the pathogenesis, and this slide pretty much says it all. On the left, you see CD8 positive T cells that are infiltrating the skin, coming to the melanocytes, secreting granzyme and perforin, and killing them. On the right, you see those arrows is where the pigment ends, and just between those arrows is a confetti-like lesion. It's only 1 millimeter in diameter. That's where vitiligo starts. There are no melanocytes there at all. So the two pillars of therapy are remove the T cells that are attacking the skin, stimulate the good melanocytes from the edges to repopulate the skin, and from under the follicles to migrate up the follicle and repopulate the skin that way. Those are the two main pillars of treatment for vitiligo. So we have to understand how vitiligo starts in the first place. Did you know that the melanocyte, just like pancreatic islet cells, are some of the most active cells in the human body? The amount of melanin that we produce every day is massive. Incredible amounts of protein per melanocyte. Well, what happens with that? You get protein misfolding, and you get something called the unfolded protein response. And that is stimulated by reactive oxygen species that are stimulated by UV light. Oh, doctor, I went to Hawaii, I got a sunburn, and all of a sudden my vitiligo came up. By trauma, oh, I skinned my knee when I slid into home plate, and look, doctor, vitiligo's on my knee. Chemicals. I use this hair dye, doctor, and look now, I have vitiligo here. Just for Men caused vitiligo on my beard area. These are reactive oxygen species that are increased because of toxins in our environment. What does that cause? It causes the melanocyte to undergo autophagy, and then you have soluble inflammatory mediators as it dies, and then the exosomes occur, and then the outermost sentinel of the immune system, the Langerhans cell, finds it, sees it, and it goes over to the lymph node. It becomes activated, and then it stimulates naive T cells to become autoreactive T cells, and this army of autoreactive, cytotoxic, melanocyte-specific T cells goes into the bloodstream, and there you have it. Now the horse is out of the barn. This person's ready to develop more lesions of vitiligo. So the kid slides into home plate, he scratches his knee, the innate immune system starts producing interferon gamma. That interferon gamma binds to the interferon gamma receptor on keratinocytes, and through the JAK-STAT pathway produces a signal called CXCL9, but especially CXCL10. That binds to the CXCR3 receptor in autoreactive T cells. Remember that army of T cells in the blood? It binds to CXCL10, and then that stimulates it to go to the melanocyte, produce granzyme and perforin, and kill it. This is the cause of vitiligo. This has all been elucidated just in the last 10 years. A lot of this by John Harris and the folks at University of Massachusetts, and actually Dr. Rashigi, he's sitting right there when he was doing research in this. So the treatment of vitiligo, what do I tell my patients? I am very blessed that I get 30 minutes with each new patient. I know that's a luxury, but that's what I need in order to explain this and to explain how I'm going to treat. That's what gets me the compliance that I need to see success in my patients. This is a long duration of therapy. You're going to be my friend for 9 to 12 months. You have to set those expectations. Patience is a virtue. I'm looking at, patients really want 80% repigmentation at least. The studies have shown that. Few patients achieve 100% repigmentation, and the visible locations are of most concern. I highly encourage you to take a photograph at every visit, because if that person is 10% better and you don't have a photograph, they won't know and you won't know, and you will give up and you will abandon the treatment. So you have to have those photographs to monitor them. So I look at the patient, I examine them, and I give them a prognosis. Better prognosis is younger patients, darker skin types, short duration of vitiligo, especially less than 2 years. Face, ears, neck, axilla, hair-bearing areas with pigmented hairs. The Global Vitiligo Foundation is trying to get the word out to the general public about vitiligo so they'll get into our offices within 2 years. If the patient's already had it for 10, 15 years and all the vellus hairs are white, it's too late. You are not going to repigment that patient. So we need to have this public type of education so that people get in earlier. So this little kid, a South Asian kid, he came in, his parents were very worried, again, the stigma of having this in India. And we treated him topically with tacrolimus and some sun exposure. And we actually treated him with dexamethasone because he had trichrome lesions and confetti-like lesions, and he repigmented very nicely. But he had only had this for a few months. Bad prognosis, older patients, lighter skin types, long duration of vitiligo, rapidly spreading vitiligo, scalp, if they have a scalp, lips, elbows, wrists, hands, fingers, genitals, knees, shins, ankles, feet, toes, areas with white hairs. That leg is not going to repigment. Do you see those 4 dots? That's where I put some blister grafts in to try to see if they would work on this gentleman. Once you have those white hairs, there's really no melanocytes from which to repopulate the skin. Hands are also difficult to treat. Now, I do dermoscopy on all of my patients. It allows me to visualize hairs because white hairs are associated with poor prognosis. I look at terminal and vellus hairs. So this gentleman came in and you would say, oh gosh, he's got pretty bad vitiligo on his forehead. Is he going to do well? Well, I pull out my trusty dermatoscope and I notice that every one of the hundreds of vellus hairs on his forehead and his cheek are black still. The vitiligo has not killed the melanocytes at the base. And sure enough, within 6 weeks, he's already repigmenting with phototherapy and a topical. And this is one of the ways that I examine and evaluate prognosis. The other thing I look for are markers of rapidly spreading disease. Trichrome vitiligo is where you have that light brown color. Do you see the white in the middle? That's complete loss of melanocytes and melanin. Do you see the light brown? That's complete loss of melanocytes, but retained melanin that's going to take 3 to 4 months to be removed from the epidermis. That person's going to come back in 3 or 4 months and all those light brown areas will be totally white and they'll say, doctor, I'm worse. And you have to explain to them there are no melanocytes left where they're light brown color of skin. You're going to get worse before you get better. And that's super important to explain. Kebner phenomenon, which you all know about. And then this one, which we described from an observation of multiple patients in Dallas. Do you see those tiny confetti-like lesions on the hand? Well, look at this patient without treatment at 16 weeks and look at her at 31 weeks. We call this confetti-like depigmentation, and now this has been recognized worldwide as a sign of very rapidly progressing vitiligo. If you biopsied one of those lesions, you would see that lack of pigment right there in the middle because the melanocytes have been destroyed. Another example of confetti-like depigmentation. Finally, before I turn things over to Dr. Hamzavi, I just wanted to remind you how important the Woods lamp exam is. My colleagues at Sunnyvale know that I get the dark rooms. I'm the vampire doc because I want a room that is completely devoid of light, no windows at all, because I need to see this guy. I need to see that trichrome on his forehead. I need to see those confetti-like lesions on his shoulder, and I do it with my Woods lamp, and that's super important to use. So just in terms of the approach to management, we have to listen to the patient's concerns and goals, obtain the history of onset, triggers, progression, and past treatments, review the effect of the vitiligo on their quality of life, examine the areas of involvement using their Woods lamp, dermoscopy, determine the area of involvement, document signs of activity, provide prognosis, review treatment options, risks and benefits. But most importantly, the treatment should be based on shared decision-making, because I'm amazed at how many patients come in sometimes with severe vitiligo and say, it really doesn't bother me that much, I just wanted to get information about what it was. Whereas others, there's one spot on the foot and they are totally totally upset about it, and they want that treatment no matter what it takes. So every patient is different, has to be approached separately.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SF Derm experience.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.